I'm just going to go out on a limb there. Okay, so again, just going back, we have scalars, which are basically something versus time, and loops where there's two parameters that are against each other. And if we can do any type of breath, and from the graphics, you should be able to tell if it's a volume breath or a pressure breath. You should be able to tell if it's a spontaneous breath. A lot of the units will either change colors or change background or something to be able to tell the difference between a spontaneous and a mandatory breath. CPAP of 5, okay, just the negative inspiratory phase and a positive expiratory phase, the pause between the two. Machine positive pressure breath, looking at a pressure tracing again, just showing that you have basically an unassisted breath. It's a time-triggered breath. Patient-triggered. What the triggering mechanism is, you don't know from the graph necessarily, but you would know from your ventilator settings. Mean airway pressure, area under the curve. A to B is the inspiratory phase, B to C is the expiratory phase. Determining a plateau pressure by creating an inspiratory pause at the end of the inspiratory phase and being able to determine. And again, we know that if that's the plateau, if I were to draw a line like that, this is the resistive component, this is the compliance component. Okay? And then this is the expiratory phase here. Here we end up having a patient who's triggering a mandatory breath on. They happen to have a pause for whatever reason built into it. So remember, this is still part of the inspiratory phase. The expiratory phase doesn't begin until the expiratory flow starts to happen. And we also have a spontaneous breath that's interspersed there, so this would be which mode? SIMV.
Great. In the last one, what did you say this circle was? The one that you
Here?
Yeah.
It's a patient trigger. So the patient's initiating this mandatory breath. As far as the flow time scalar, we typically either have a square wave flow pattern or a decelerating ramp flow pattern. Don't see sine anymore. Theoretically, you could have an ascending flow pattern, but again, at the initial portion of inspiration, you want as high of a flow as possible. Otherwise, patients don't feel comfortable with it. And again, this area under the curve represents flow per unit time or volume. So this would be the inspired tidal volume, this would be the expired tidal volume, and in theory, they should be exactly the same. I don't like that color. Come back here, you. Red. So we have an inspiratory phase. We have an expiratory phase where I have an expiratory flow and an expiratory pause. So at some point as you're exhaling, you reach the 0 point and you're just waiting for the start of the next inspiratory breath. Does that make sense? And then finally, we have a volume time scalar where I end up having an inspiratory phase and an expiratory phase coming back to 0. This would be what my tidal volume would end up being. So probably about a 1 liter tidal volume, looking at that. Getting on to the loops then, we have 2 loops. This is a pressure volume loop. This is a spontaneous breath. How do I know it's a spontaneous breath? Because I have something going negative. Ordinarily, pressure wouldn't, this is pressure along the baseline. Pressure would never be negative on a positive pressure mechanical breath, only on a spontaneous where you're creating some negative pressure, generating a tidal volume, and exhaling it back out. So this is the expiratory phase, this is the inspiratory phase. Now the weird part about this tracing is it's probably taking close to 10 centimeters of water to trigger it on. Or not to trigger, let me rephrase that. They're generating a pressure of 10 centimeters of water. That's an awful lot of pressure. Normally you would only see a smaller drop back. So there's something related to why they were requiring so much water pressure to generate a breath. But that's a pressure volume tracing, and I know it's a spontaneous simply because it's got a big negative component.
Now, the inspiratory, the amount going in and out should be the same?
As far as the volume, yeah.
And if you, will you see something different then if they have
Sure.
compliance or resistance? That's how you kind of...
I don't know. And in reality, we really don't always exhale exactly what we take in. There's going to be a little bit of variance that is in there on a breath basis. Yeah.
I'm not a graph expert, so...
Yeah, you are. You're going to be after today. You're going to be a graph expert.
So if they were polling like if they were more negative this way, so it would be
If
more
they were-
to the left?
Yes.
Yeah, okay.
That means they're drawing more.
Does that mean that it is an indication they have auto peak?
Could be. Could be something, well, let me rephrase that. If they're probably not an auto peep on a spontaneously breathing patient, doesn't quite
Right.
work that way. Auto peep is specifically with mechanically ventilated patients. But this might be something where you're seeing a big drawback negative. Could be if they were on a mandatory breath, if it took a lot to trigger that breath on.
Like sensitivity?
Pardon me?
Yeah, sensitivity would be off.
Could be the sensitivity isn't correct.
On
Yeah.
a spontaneous.
Yeah, you still have a spontaneous trigger that you have to have to open up the valves.
Okay,
And there's another example of a pressure volume loop on a mandatory breath, because everything's on the positive side of the tracing. I know that the patient is on 0 end expiratory pressure. How do I know that? Because it comes back to 0. This is my peak inspiratory pressure. This is the tidal volume that is generated with that. Inspiratory is always on the bottom, expiratory is always on the top. And you can see that, like a balloon, there's actually two different slopes that are here. Okay. And Mary will talk a lot about this in the fall, but this is actually what is called the lower inflection point. And it has some relevance as the point at which the airways are popping open. So if you think about it, I shouldn't say airways, alveoli. If you think about it, when you're blowing up that balloon, there's some point when you're inflating that it becomes easier. There's some point at which it becomes easier. Remember, this slope is related to compliance. The more the slope goes this way, the better the compliance is. Go ahead.
If you would peak, how would your volume,
It would start here.
but the volume as well would start there?
Yeah, the volume would start at 0 and would go something like that. Okay? So that's a pressure volume loop, and you can tell that as this over time goes in the counterclockwise or goes towards the y-axis, compliance is improving. As it goes in the opposite direction, compliance is becoming poor. To some extent, the width of this is a relationship to airway resistance. And I probably don't want to get too much further than that. But here's my starting point at FRC. I rise up to my peak pressure, and I exhale back down. It's again just showing the same exact thing. And finally, there's a flow volume loop where you're looking, again, we went through this with PFTs, but basically this would be the inspiratory phase, this is the expiratory phase, and the volume that is involved as you're taking the breath in. So this would be starting at FRC, starting at the beginning of the breath, and this is the end of the inspiratory phase and the beginning of the expiratory phase. So what do we use these things for? Why do we care? Why are we monitoring this? Well, there's a bunch of different things you can pick up on. Some of them are here. We can tell whether or not, yeah. I can tell whether or not medications are working. I can talk about why the alarms are going off. I can look for overdistension, auto peep, whether sensitivity is set appropriately, and whether the flow rate is adequate during volume control, or am I flow starving my patient. So this is the kind of thing that you might see on a test where I show you a graphic and I say, what's happening? How would you fix this? Okay. Normally, when you're in the ER and you're giving a breathing treatment, how do we know that it works? We give them a peak flow. We monitor the peak flow prior to the therapy. We monitor the peak flow after the therapy. And we can say whether or not it improves. This is peak flow. Okay? As the patient, this expiratory phase is totally dependent upon the patient. The shape of this is totally dependent upon the patient. This we set in volume-based ventilation. But as the patient exhales, the degree to which, that is one awful looking curve. I just have to say this. Let me try that again. So as that peak flow improves, I know that my bronchodilator works. If I don't see improvement, then I know that either the therapy, the dose wasn't correct, or the patient's unresponsive to the medication.
The red one is after the therapy.
That's aft, right. A higher peak flow has been generated. Duh. And in theory, in actuality, this probably should come back a little bit less so that we have a shorter expiratory time, because I can exhale more flow. I can therefore exhale that same volume in a shorter time. Am I good on that one? Assessing peak flow. So here we ended up having our pre, and here's our post. And you can see that this improvement showing that the bronchodilator therapy worked. Looking at the same thing on a flow volume loop, here my peak flow is something less than 60 liters per minute. Here my peak flow is almost double where it was at. Okay? So peak flow has improved with bronchodilator. Can also see it's specifically improved in those mid-airways, where the bronchodilator, your conventional albuterol, should work best at the medium to small size airways. I'm ventilating my patient, and we're setting our high pressure alarm where, by the way? Where do we set our high pressure alarm?
10 to 15.
Above what? Above our measured pressure, right? Above our PIP. And we know that it could either be a compliance problem or a resistance problem. Okay? And we need to assess which is which, and how do we do that? We go ahead and we look at the difference between the PIP and the static pressure. Okay? Or plateau pressure, I probably should say that. If they both went up, we know it's compliance. If only one went up, if the PIP is the only one that went up, then we know that it's a resistance problem. Low pressure alarm typically is associated with a ventilator disconnect. The ventilator disconnect or a leak, we can very quickly identify a leak by looking at the volume waveform, as we will see. And again, if you cannot quickly identify the cause, we know that we want to use a resuscitation bag. So here's my volume time tracing. And you can see that there's a tidal volume that's being delivered. This is 0.4, 0.8, 1.2, so tidal volume is about 1 liter, right? Everybody see how I got that? This is 0.4. This is 0.8. This is midway between 0.8 and 1, 0.2. So it's got to be 1. Okay. But when I exhale, I'm not exhaling back to baseline. They're only exhaling to this point. So that means that I have about this amount, 200 milliliter leak in the system. I can quantify how much leak I end up having. What is being put in is 1.0. What is being exhaled is only 0.8. So there's a discrepancy of 200 milliliters that is there. Go ahead.
How do you know that's not air trapping?
How would I know it's not air trapping? No. Go ahead.
Because air trapping would auto-correct itself after a while. It would show maybe on the first 2 breaths.
And the third one.
The third one or so, it'll say, okay, then that's the normal
Oh, like
volume
a,
coming
like a,
back.
auto peak would start showing?
You won't see the
Well,
auto
right.
peak on the tidal volume, but then it will say, okay, you'll always see the auto peak on the flow curve, but then the volume itself will say, okay, that's the volume, and then the volume curve itself will say, that's the volume that's coming, it's returning all the time, but it's trapping.
So say I am trapping a couple. At some point, the patient's just going to exhale a larger tidal volume than you put in.
Oh, okay. And
Okay.
that's where the machine will know. that.
Yeah, you'll see it actually go into the negative. Yeah,
Okay.
meaning that they put out more than they put in. But if you're seeing this consistently, that's a classic sign of a leak.
When you do the auto peak maneuver, you will see on the volume curve, it go below the baseline, meaning it's exhaled all that extra gas that's trapped, but it will self-correct. You will
And
see it,
You could look then at the flow.
Yeah, you would tell. You would. Yeah.
Right. And then you could compare.
right, and if you catch the auto trapping occurring, you will see it on the first couple of breaths, but then it'll self-correct itself and say, okay, and it'll give that same volume every single time I return, because that air trap will always stay there.
But with leaks, it's consistent. Identifying leak from another way. This is a flow volume loop. Here I have a inspired tidal volume. Here I have an expired tidal volume. There's some volume of air that's not come back. What I put in, what's returned, are different values. It's got to be a leak. Same thing on a pressure volume loop. Ordinarily, this curve should come back to the 0 point. Because it's ending before it gets all the way back out again, I know I have a leak. So anytime you have a volume as part of the tracing, you should be able to pick up on a volume leak.
This sounds stupid, but where is it leaking?
Don't know. Somewhere between the patient,
And the circuit.
well, somewhere between the ventilator and the expiratory valve. So where it's meeting inspiratory flow and where it's coming back and seeing this portion of the tracing, this inspiratory limb, the ventilator is delivering. This is all on the patient end, so somewhere between the patient and the expiratory flow transducer, there's some volume being lost there. Where? Oh, find it.
You gotta go and check all your connections.
Yep. I've actually used a stethoscope to be able to just listen along the way and see where something isn't fitting. Could be the cuff, yeah. Somewhere along the line. So let's take a look at this curve. A couple of things that we have here. We have a square wave flow pattern. So what type of breath is this?
Pressure.
I have a square wave flow pattern. So what type of breath is this? It's a volume-oriented breath, right? Because flow is fixed, I know that the pressure is going to be the variable component. Somebody in here was asking me, or was it the other class, where they were saying, if I see a square curve, do I know that that thing is the thing that's being controlled? And I said, yeah, it's probably true. In this case, I have a volume-based breath and a pressure curve that's going to be very different. Now, the dotted line is what you expect to see. The solid line is what we're actually seeing. Okay? So what I end up having is I end up having an airway pressure that's lower than expected, a flow on the expiratory component that's less than expected, and a volume that's not coming back to baseline. So if I have a leak in the system, I'm not going to return all my gas, but at the same time, I'm also not going to generate as high of a pressure, because some of that pressure needed to inflate the lungs is going to the atmosphere. That doesn't make any sense at all, does it? Remember, everything on the ventilator is delivering, so this portion of it is all based upon the vent. A couple things you notice is that the airway pressure is less than I expect to do, so something's causing it to not generate as high as a pressure. Well, it could just be the compliance improved, it could be the resistance got less. Those would cause less pressure than you would expect. However, the fact that these two don't match up, the area here and the area here, this second one's a lot less. The space occupied, this should match that. It's not. So that means that my inspired tidal volume and my expired tidal volume are totally different. I can also tell that on a volume tracing, because this is the amount they put in, 1 liter, I've only exhaled back to here, whatever that works out to be, probably I've only exhaled 0.8. Oh, I got a leak somewhere in the system. Yeah.
Does it show the dotted lines on the ventilator or
No.
Then how do we know that?
I'm just telling you from this back. How do I know I got a leak? I know I got a leak because the volume doesn't come back to
Right.
baseline.
The other ones, the solid one?
Yeah, you wouldn't.
Yeah, how do you know that this is supposed to be all the way down, like a bigger one instead of a smaller one?
The flow I know simply because the area here should match the area there. The pressure I don't really know. Okay? Go ahead.
If we're putting in 1 liter volume
Mm-hmm.
and flow is fixed,
Mm-hmm.
and my pressure doesn't generate, how will I hit the 1 liter volume?
Oh, it'll still put the 1 liter out.
But won't it keep like going?
It'll go to the
It's not
atmosphere.
hitting it?
It'll just go to the
Oh,
atmosphere.
It's still hitting the 1 liter value wise, but you're not necessarily putting that in the patient.
Yeah,
Okay.
exactly.
Okay.
Or, it's going around the trickle to cuff.
Right.
Okay. Lung distension. We talked about that this morning. We know that we use positive pressure to inflate those lungs, and the over-distension is the problem because it can be something that leads us, or it occurs during ARDS, but I should say a precursor to multi-organ failure associated with ARDS. And what we've adopted, or what we try to encourage people to do, is use a lung protective strategy in the concept. So again, here's my positive pressure breath. I'm starting from ZEEP. I have a period of pressure where it's not a whole lot of change, and then all of a sudden you have that rise in pressure. Here I end up having basically, again, you can see the two slopes that are there. This would be my lower inflection point. And as I increase the tidal volume, I really don't over-distend because that pressure is not going horizontal. When you see that happening, here was my initial pressure volume loop. I now increase the tidal volume from 0.8 to 1.0. Instead of continuing on up, it now changed slope. It now went, there's my lower inflection point. There's a slope here. And there's another slope here. This is actually called the upper inflection point. It's the point at which the slope changes again. Well, if I'm over-distending, if I'm putting too much volume into that alveolus, that's going to actually make the compliance fall. because I can't put any more in there. It's getting stiffer. So I start off, I rise, and then I come back again. The point here is, why are we putting this extra tidal volume in when it's to put 200 more milliliters in, it's taking 10 centimeters of water pressure to do that. You're wasting your time at that point. Does that make sense? I know Mary does cover that in the fall, right? Yeah, okay. But just to give you an introduction to the concept of inflection points and that overdistension identified by looking at the beaking. Come on, you. This is the bird's eye. This is his mouth. And that's his beak. His mouth is, well, in the beak. Yeah. But not the upper portion of the beak, just the lower portion.
When would someone be aggressive with that when they're just having a hard time oxygenating, so they want to go to the upper?
I have a situation where I'm in ARDS and I want to go ahead and blow off more CO2, so I opt to increase the tidal volume as opposed to increasing the rate. And I've overdistended. And at that point, it's like, no, bad move. Go back. Another example of overdistension. You can see that at this point here, you start having a change in slope again, where it's rising this way and then it goes more horizontal, which is a sign of falling compliance. Auto peak. Flow returns to zero. Flow does not return to zero. Auto peak is present, and what do? We go ahead and we measure it and quantify it. If it's significant, you want to go ahead and correct for it, fix the cause, or you can apply extrinsic peak to combat it. And here you can see the presence of auto peep. So you detect auto peep from the flow time tracing, a pressure problem from the flow tracing. This doesn't seem right. Sensitivity, this pressure drop, if I'm in pressure trigger, should be what my pressure sensitivity is set at. If I see instances where I see a patient attempting to trigger, but no gas being delivered, I know that I have a loss of triggering, so that means that I must have the sensitivity inappropriate, or there's auto peak present causing that sensitivity to not be sensed. That doesn't sound right, but you got the idea. Can everybody see that pressure, how I'm attempting to generate something? These are patient efforts that are not being matched with a delivery of any tidal volume. Here I have a patient who's drawing back 5 centimeters of water to trigger the breath on. Shouldn't have to draw that much. Either the machine is not responding appropriately and the machine's defective, or my sensitivity is not set correctly.
Can that be auto peak too?
But you wouldn't see it necessarily on the tracing. Yes, it could be caused by auto peep, but again, I read auto peep off the flow tracing, or I see the presence of it off the flow tracing, I should say. Same thing here. This is now. Let me ask you a couple of questions on this. What is my level of peep?
5.
How'd you get 5?
Starts at 5.
Starts at 5. So that's my level of peep. This is the inspiratory phase. I'm drawing back, and then it's going up. So this is actually going in that direction. This means that my sensitivity is not very sensitive, because I got to draw back from 5 all the way back to 0 to trigger the breath on, to have it start moving in the opposite direction. Okay. This is, if you think of this as a figure 8, I'm starting here. The machine turns on, starts its delivery. The patient exhales back. But this dotted is where we're supposed to be, but this is telling me that there's a 5 centimeter of water pressure change that has to occur to trigger the breath on. inappropriate sensitivity setting.
But it should be what, like 2?
Should be about half that, 2 to 3. Yep. And that's basically what we're just talking about. That's the level of PEEP. That's the inspiratory effort. Inspiratory phase, expiratory phase. Tidal volume being delivered is that the height of that. Okay, flow rate setting during volume control ventilation. We come up with all kind of formulas to try to get to a 1 to 2 to 1 to 4 IE ratio. It's probably the hardest thing to set because we're setting them up when they're perhaps heavily sedated or maybe even paralyzed. And then when they start to wake up after the surgery, they got a tube in place, they're confused, they start trying to draw more gas, and unfortunately the flow rate is fixed and won't allow them to happen. That's why dual control ventilation is nice, because it's a pressure-based breath and they can draw whatever flow and volume they want. However, we need to remember that the ventilator doesn't respond to increase in demands. It just lowers the pressure if it's seeing a bigger tidal volume than what it thinks it should be doing. So we're going to watch the pressure curve to tell if the flow is appropriate, kind of backwards. Okay, where we looked at auto PEEP on the flow tracing, we're going to look at flow starvation on the pressure tracing. And here we end up seeing a patient who has adequate flow as a dotted line. Somebody then who is continuing to create a negative pressure never quite reaches that tracing. Okay? Never quite gets to that point. They're always sucking a little bit behind. So you see a big scooping out of that curve. That's a sign of a inadequate flow being applied. Okay? So here I have a little bit of that scooping out. It's not, because it should be this nice. Actually, let me change that. This curve should look like a straight line. It's got a little bit of a scooping out. So that must mean that there's some inadequate flow. I go ahead and I increase my peak flow. And now I have a nice straight line rise. Okay. And that's it.